But in terms of respiratory rate, your respiratory rate is just how many breaths you do per minute. On average, it's anywhere between 12 to 20. That's going to be the normal respiratory rate for a healthy individual. If you're above 20, then you're starting to become tachypnic. That means you're breathing too rapidly. Generally speaking, when a person's tachypnic, it means that they're in respiratory distress of some sort. Maybe they have an infection. Infections are very common for tachypnea. Maybe they're having some form of like asthma attack, or maybe even having like a panic attack. That can make somebody become tachypnic as well. And then when you're tachypnic, you're going to be breathing off a lot of carbon dioxide. So if you're breathing really rapidly, if you're hyperventilating, then you're going to start becoming alkalotic, because your pH levels are going to start going up, because as you breathe out carbon dioxide, the more carbon dioxide that's in your system, the more acidic you become. You become acidotic, so pH levels go down. If you breathe off your carbon dioxide, then you're going to become the opposite. You're going to become alkalotic. Okay? So that's all involved with respiratory rate. Okay? And then we're going to talk about the different regions of the brainstem, the pons as well as the medulla, that are going to be involved in controlling respiratory rate as well. You have voluntary and you have both involuntary controls as well. So you can obviously think about breathing, so you can control your breath, inspiration and expiration, but generally speaking, a lot of our respiration is completely involuntary. We don't think about it. And then tidal volume, when we're looking at the pulmonary function test, that's what we're all just doing right here, right now, right? We're just sitting there, we're relaxed, we're doing regular tidal volume, tidal breathing, right? Generally, for a normal, healthy adult, it's about 500 milliliters of air per breath. So that's just sitting there, you're breathing 500 mLs, you exhale 500 mLs. That's tidal, that's regular tidal respiration. So we're going to talk about how that's going to be important in calculating different values for your pulmonary function test. The other thing that you can do with the values like tidal volume as well as your respiratory rate, you're able to actually calculate your pulmonary ventilation. Your pulmonary ventilation is the total amount of air that you're breathing in and out within 1 minute. However, not all the air that you breathe in is actually going to make it down to the alveoli. Whatever air does not make it down to the alveoli is going to be trapped within what we call dead space. Okay, so dead space is going to be air that isn't going to be actually functional, right? So you're breathing in, the air that makes it to the alveoli, that's going to allow for actual respiration and ventilation. However, the dead space, the air that's trapped within like your trachea, for instance, that's going to remain there and it's not going to be actually functional. So to be able to actually calculate the alveolar ventilation, you can do the same type of calculation involving tidal volume and respiratory rate. However, you're going to also subtract anatomic dead space from the tidal volume. All right, so if you just wanted to calculate pulmonary ventilation, that's going to be respiratory rate times the actual tidal volume. So respiratory rate, say for instance, you're breathing 20 breaths per minute. If your tidal volume was 500 mLs per breath, you'd be multiplying 20 by 500. Okay? Versus alveolar ventilation, you're going to be accounting for that anatomical dead space, the air that's going to be basically trapped in your trachea, that's not going to make it down to the alveoli. And then so you do tidal volume minus the anatomical dead space, and then you take that value and you multiply that by the respiratory rate. Okay? So this is what that pulmonary function test looks like. We looked at this last time we met. Okay? So you have just sitting here, normal, you're relaxed, you're not doing anything crazy, you're not exercising, you're not running, you're undergoing just normal tidal breathing. And so the value for that, on average, is going to be about 500 mLs for a normal person. Now, if you're all of a sudden taking a really deep breath in, right, you're taking in the maximum amount of air that your lungs can tolerate, that's going to be the inspiratory reserve volume. Okay, so inspiratory reserve volume does not include tidal volume. It's going to be everything above tidal volume. If you combine inspiratory reserve volume plus tidal volume, that becomes your inspiratory capacity. Okay, so Now, if you're undergoing regular tidal breathing and then you let out all the air from your lungs, as much air as you can possibly release, that's going to be your expiratory reserve volume. Okay? So, now, one thing to keep in mind about when you breathe out, you're not going to breathe out all the oxygen or air in your lungs. Right? Remember, we talked about this last time. There was a couple factors that were really important when we talked about water surface tension. Right? What was the important chemical that helps to counteract the effects of surface tension? Surfactant. Awesome. What type of cells produce surfactant? Do you remember? Type 2 pneumocytes. Good. All right. So surfactant is going to be really important, but also you have to have a little bit of air left inside your alveoli. Right? The alveoli need to remain expanded. Otherwise, if there's no air in there, they're going to collapse. And if they collapse, it's going to be really hard for them to re-inflate. And so there's always going to be a little bit of air left behind, and that's going to be called the residual volume. All right. Generally speaking, you can't really calculate residual volume. It's always going to be kind of an estimate of the residual volume. It's about 25% of the total lung capacity, roughly speaking. Now, if you combine all of these different regions right here, the expiratory reserve volume plus tidal volume plus the inspiratory reserve volume, that's going to be what we refer to as the vital capacity, right? So vital capacity, also referred to as VC, that's going to be the amount of air, the total amount of air that you're breathing in and out. But that's not including the reserve volume. The residual volume is always going to be, there's always going to be a little bit of air left behind. Now, if you were to include the reserve volume plus the vital capacity, that's going to be your total lung capacity. That's all the air that you're able to, that your lungs are able to accommodate. Okay? So we're going to learn how to calculate these. I'm going to run through a bunch of practice questions in about 10 or 15 minutes so that you guys can have a little bit of practice in calculating these different values. So let me move on. All right. Now, these values over here, these are going to be kind of just rough estimates of average values for each of those different values that we're looking at with the pulmonary function test. So tidal volume, both for males and females, is going to be about 500 mLs of air. That's just going to be you sitting down, breathing without any extra demand. So that's going to be 500 mLs. But these other values, you know, they're going to change from person to person. Some of these values might actually be reduced depending on the size of the individual. There are charts out there if you want to do like estimates of what some of these values look like. You can actually do it by gender as well as by age. So older people, generally speaking, they might have less accommodation in their lungs, right? They might have less flexibility within their lungs. So some of these values might be a little bit reduced. Individuals that are, you know, shorter stature, they might also have reduced values as well. Larger individuals, taller individuals are going to have larger values. But generally speaking, tidal volume is the one that kind of remains constant despite age and despite gender. So it's usually going to be about 500 mLs per person. So let's watch a little video on pulmonary function test. Very short. Make sure that the volume's on. Okay, let me start that over again. Turn the volume up here.
Right, so we're going to do a test with you which looks at how much air you can take out of the vomiting breath, how well the air flows out of the breath as well. Hi, hello.
Hi, I'm Stephen Silver.
I'm Chrissy Hensley Turner and Stephen Country. I'm Bristol Union, Bristol West.
Yeah, I'm people from Bristol Union and Bristol West. My main distance is 1500 metres.
So I'll just pop these onto your nose, hold on to this, let's find some tight on there, normal breathing. Start off with, then take a big breath in, and as soon as you land control, I'm going to blow and blast the air out, try to pass it. When you're ready then, really big breath in, and blast. Keep going, and then really big breath in, really fast. Yeah, well done. Imogen managed to get out 4.45 litres. The predicted value was 3.77 litres, and she had predicted 100.
All right. So the long story short is athletes as well as people who exercise regularly and get a lot of cardiovascular type workouts, they're going to be able to increase these values, right? Because they're able to like constantly increase the demand for oxygenation. And so you can actually, through your activities of daily living, your workout routines, you can help to increase and improve some of these values. Now, these values are also going to be affected by other types of lifestyle activities, right? So like people who smoke cigarettes, for instance, they're going to be predisposed to COPD, right? So that's chronic obstructive pulmonary disease. They're also going to be predisposed to emphysema. I'm going to talk to you about the difference between COPD and emphysema in a little bit. Asthma can also affect these values too. So any of you guys in this class that might have asthma, you've probably done these tests in the past in the clinic, right? So those are pulmonary function tests that can help to identify the severity of your asthma, and they can also sometimes use certain types of triggers, right? Sometimes they'll use noxic stimuli or chemicals to be able to induce allergic reactions as well as asthma, and then they'll do a pulmonary function test as well, just to see if, what kind of effects those compounds might have on your lungs. Now, what they did when they were breathing in, so they breathed in all the way, so they had like maximum amount of air in their lungs, and then they breathed out as rapidly as possible. Now, what that gave them was the functional, the forced expiratory volume within 1 second. So that's the total amount of air that they're able to force out of their lungs within 1 second. Now, that value is going to change depending on what's going on with the individual's lungs, assuming that there's an underlying pathology of some sort. Now, with COPD, which is going to be on the left side over here, COPD, emphysema, basically what you're getting is air trapping. Air gets trapped into the lungs. It's really hard to get the air out of the lungs, especially with COPD. With COPD, they're going to get chronic bronchitis. Eventually, they're going to start getting what we call barrel chest because, eventually the alveolar sacs are going to start getting hyperinflated. And as they get hyperinflated and less elastic, then air is going to get trapped within their lungs and they're going to have a really hard time pushing it all out. And so the forced expiratory volume within 1 second is going to be markedly reduced. So you'll get a less than 70% value when you divide the forced expiratory volume in 1 second divided by the vital capacity. By the way, those equations I'm not going to have you guys do since you guys can't use calculators on the test. I'm not going to make you guys calculate percentages, but just kind of have a general idea of what's going on with these different types of conditions. Now, with restrictive disease, so this is going to be the opposite. Restrictive disease, for instance, with pulmonary fibrosis, the lungs are going to have a really hard time inflating. Okay, so it's the opposite of obstructive disease. Obstructive disease, you have no problem getting air inside the lungs, but you have a hard time getting the air outside of the lungs. Now, with restrictive disease, like pulmonary fibrosis, you can't get enough air into the lungs. So your forced expiratory volume in 1 second is actually going to be pretty rapid, because think about it as like a really elastic balloon that you have a hard time filling up. Okay, so if you try to fill that balloon up, you're going to have a hard time doing that. And then as soon as you let go of the balloon, all of a sudden all the air is going to come out really rapidly. That's kind of the concept behind restrictive pulmonary disease. So pulmonary fibrosis, also obesity, can mimic some of the effects of pulmonary fibrosis by making the forced expiratory volume in 1 second really rapid. So you have a really hard time bringing air in. So you have reduced expansion of the lungs. Now, when you guys go into clinical practice in the future, when you're in the hospital, especially if you're working in cardiovascular type units, even if you're working in primary care, you're going to see a lot of patients that have COPD. You're going to see lots of patients that have emphysema. Now, a term that you're going to hear thrown around are going to be blue bloaters as well as pink puffers. Blue bloaters are going to be individuals who suffer from COPD. Generally speaking, some of the trends for quote-unquote blue bloaters, they're going to be blue. That's cyanosis. That means they're not actually able to get enough oxygen coursing throughout their systemic circulation, and so they're going to be kind of bluish in their tinge. Okay, so that means that they're cyanotic. They're not getting enough oxygen. They might have elevated levels of hemoglobin. Why do you think their hemoglobin levels are going to be elevated? What happens if you're not getting proper oxygenation in your body? You guys remember the hormone that's released? The increased red blood cell count? Remember blood doping? We talked about that earlier on. EPO, does that ring a bell? Erythropoietin, do you guys remember that? Okay, so if you're not able to properly oxygenate tissues, then your body is going to reflexively release more erythropoietin. You're going to get more production of red blood cells. So these patients generally tend to be a little, start to get polycythemia. Okay, so they have increased red blood cell count. They're also going to have elevated hemoglobin levels as a consequence. That's just their body's a body's attempt to try to overcompensate for the difficulties that it's having oxygenating tissues. You're also going to get some other effects like bronchi and wheezing. That's all going to be secondary to chronic bronchitis. So these patients generally have chronic bronchitis, and they're going to have a very difficult time breathing. So they're going to be they're going to have cyanosis. They're also going to have a thing that's kind of interesting. So with air trapping, I don't have any videos of this, which kind of show you, that would maybe potentially show you the mechanisms of this. But if you guys have a COPD patient in the future, you're going to notice that they might start doing pursing of their lips. So when they purse their lips, they're pushing the air out through a smaller aperture, and because of the physics behind that, they're able to release more air from their lungs. But because of the pursing of the lips, they're going to have prolonged expiration. They're going to have a really, it's going to be a hard time releasing all the air from their lungs because of the air trapping. But with the pursing of the lips, they're able to get more air out. Okay, so that's one thing that you might see. So prolonged expiration. Now with pink puffers, those are going to be patients that have emphysema. With emphysema, basically what's happening is that the elastic tissues at the levels of the alveoli have degraded, and so now the alveoli aren't able to contract, releasing air as readily as they otherwise would. So these patients are also going to be having a hard time breathing, so they're going to have dyspnea. They also are going to probably have a body habitus that's a little bit more like cachectic, so they're going to tend to be a little bit thinner compared to patients with COPD. So these are just some things for you to look at, or some things for you to keep in mind when you're working in the future with these types of patients. So blue bloaters and pink puffers for COPD and emphysema, respectively. COPD, one of the major risk factors for COPD is going to be smoking. So don't do what this dude is doing. So back in the day, before a lot of research came out about the dangerous effects of products of combustion, cigarettes in particular, it was thought by especially the tobacco industry that these things were actually good for your health. So they had all these propaganda campaigns back in those days, trying to convince the public that, hey, your doctor smokes cigarettes, you should too. So anyways, fun stuff. Nowadays, we obviously know that smoking is going to be a huge risk factor for conditions like COPD, as well as many other things like lung cancer, things like that. But these are going to be some other risk factors for COPD. You can have cadmium dust, certain types of silica dust, welding fumes, so people that work in industry might be predisposed to this. Coal dust, coal miners. There's a condition that we call black lung. Fortunately enough, we don't see it as much anymore, but back in the day, like early 20th century, when a lot of our energy generation was through coal, and coal miners had to go living basically underneath these little tight corridors and tunnels and mountains, digging up coal, they'd be breathing in all that coal dust. And that coal dust would eventually result in black lung. The symptoms are very similar to being a chronic smoker. So those patients would have lifelong consequences just by virtue of their job. So pretty unfortunate. So any questions about COPD, emphysema, and restrictive pulmonary disease? All right, cool. So let's talk about some of the gas laws. Last time we met, we did discuss one of them. We discussed Boyle's law. So with Boyle's law, if you recall, we were talking about the mechanisms of breathing, right? So what happens when you take an inhalation? What happens to your diaphragm? Does it remain relaxed or does it contract? So it contracts, right? So as your diaphragm contracts, the volume of your thoracic cavity is going to increase, right? And Boyle's law states that as you increase the volume, you're also going to decrease the pressure, right? As you decrease the pressure, the interalveolar pressure in particular, now the atmospheric pressure, which sits at around 760 millimeters of mercury, the atmospheric pressure is going to be greater than the interalveolar pressure. That means now air is going to be able to push into your lungs. All right, so that's Boyle's law. Dalton's law, which we're going to talk about in a second here, Dalton's law basically just talks about how the partial pressures of each individual gas or compound in a gas is going to add up to the overall pressure of the gas. So, for instance, the partial pressure of nitrogen versus the partial pressure of oxygen plus the partial pressure of carbon dioxide. All those are going to add up to combine into the overall total pressure of the gas. And then Henry's law, if you guys ever use a soda stream or something like that at home where you're forced carbonating water, that's Henry's law. As you increase the pressure of the gas and it's coming in contact with the fluid, now you're going to be pushing the gas into the fluid. So that's kind of like the concept behind carbonation. So we're going to talk about that in a second here. Now let's talk about the composition of air real quick. Air is actually not mostly oxygen. The majority of air is going to be made up of nitrogen. So it's almost 80% of all, almost 80% of air is going to be made up of nitrogen. Oxygen is going to be about 20%, and carbon dioxide is going to be a really small percentage of air. Now this is Dalton's law. So over here you have the partial pressure of oxygen, say for instance 159 millimeters of mercury. If the partial pressure of nitrogen was 593 millimeters of mercury, all you do is just add those together, and now you have the overall pressure of the gas within that space. So that's going to be Dalton's law. Pretty straightforward stuff. Nothing too crazy. Henry's law is a little bit more interesting. That's the one, as I just mentioned, is going to be associated with like carbonation. So like forced carbonation. When you open up a can of soda, now you reduce the pressure within that vessel, and then all of a sudden carbon dioxide comes out of solution, right? So as carbon dioxide comes out of solution, that's when you get the fizziness of your soda. So that's going to be dictated by Henry's law. So let's watch a little video on that.
Water is often called the universal molecule. As a polar molecule, it is really good at holding polar and ionic compounds. In addition to dissolving solids such as salt and sugar, molecules in gas states also dissolve in water. The amount of gas that dissolves in water is described by Henry's law based on work done by the scientists. The law states that at a constant temperature, the amount of a given gas that dissolves in tight and volume of liquid is directly proportional to the partial pressure of that gas in the air above the liquid. The wordy way to say that the more of a gas there is in the air above the liquid, the more of that gas will dissolve in the liquid. The relationship is expressed mathematically as C, where C is the concentration of the gas in solution, K is a constant partial pressure of the gas in the air above the liquid. For any particular gas, this is a linear relationship. The constant has to be experimentally determined for gas, liquid, and temperature combination. There are conditions where this relationship does not hold, but in general, it does a good job of describing patterns of gas solubility in many real-world conditions. One that we all experience is the behavior of bottles of tank cans of carbonated drink. Carbonated drink has carbon dioxide added under pressure before the bottle is sealed. None of the bottle's partial pressure of carbon dioxide of the liquid is 100%. A had mentioned that constant K has to be determined for gas at different temperatures. The solubility of gas decreases with it. That is, the warmer a liquid is, the less acid it can hold. This is also something we have experience with carbonated drinks. If I were to offer you a choice between two drinks, one that just came out of the cooler, another that has been out in the sun on a warm day, which would you say was more likely to explode, spewing liquid all over the room? Most people would say immediately the warm bottle is most likely to make a mess. This is because the warmer water has less ability to hold carbonation. The bottle is open, and the partial pressure of carbon dioxide in the space above the liquid drops from 100% to 1%. Carbon dioxide will come out of the warmer bottle much faster.
All right, so you guys get the idea. So it is going to be temperature dependent as well. So one thing to keep in mind with Henry's law. So I'm going to skip this. This is from your textbook. That kind of goes into more details about Henry's law. But let's talk about a real life scenario where Henry's law could come into play. Now, carbon dioxide is extremely soluble within water. Okay, so it's going to be able to stay within solution for a longer period of time. Right? So oxygen is actually not as soluble as carbon dioxide. So if oxygen is within water, eventually it's going to come out of solution at a much rapid rate than carbon dioxide would. Nitrogen is even lower than that. Nitrogen is going to have a very low solubility. And now remember how much nitrogen is in the air, right? About 80% of all the 80% of air is going to be made up of nitrogen. And so we're going to be breathing in nitrogen all the time. Now, when a diver is scuba diving, right? So they're going to be experiencing a lot of pressure underwater. And because of that great amount of pressure, now gases are going to start getting into solution, into your blood, which isn't necessarily a bad thing. It is bad, however, if you are really deep in the water and you start to rise up out of the water at a more rapid rate. Now, that results in a thing we call decompression sickness, also known as the bends. The bends is extremely dangerous. Some people can get all sorts of complications from the bends, including things like stroke, for instance. Because if you have all of a sudden nitrogen coming out of solution in your blood, now you have gas just floating around in your blood. That gas can get trapped into vessels, and it can cause ischemic type occlusions. In order to be able to treat the bends, if a person has like a more mild version of it, generally the major treatment is going to be hyperbaric therapy. So you're going to be put into a chamber, you're going to be exposed to oxygen at 100% so that you're able to get rid of the nitrogen. But actually, when I was in med school living in the West Indies, a lot of my friends, they used to be scuba divers. They got scuba certified. I had a couple of friends that got decompression sickness, and it's a very, very painful condition because you'll get nitrogen trapping into your muscles, getting into different areas in your body, and it can be extremely uncomfortable. So, any questions so far? Let's go ahead and do the part 3 of quizzes, and then we'll continue after that. So go ahead and log in. So, okay, there we go. All right. So I counted 54. So If anybody's having a hard time logging in, I'm going to go ahead and hit start. If you couldn't log in, then just give us your name. Okay. Taking off? Luck on Thursday. Yeah. Yeah. Okay, cool. Awesome. All right, have a good one. Take care. All right, good. Looks like most of you guys got this correct, which is awesome. So, we didn't talk about this today, but we talked about it last time we met. A person with asthma, you're going to get bronchoconstriction. Right? That's going to be one of the major things that's happening with asthma. You get mucus plugs as well, but bronchoconstriction is going to be one of the big concerns. And so if you use albuterol, which is going to be attaching to the beta-2 receptors, the beta-2 adrenergic receptors, it's going to cause bronchodilation, which is going to be basically a sympathetic response, right? So if you're in a sympathetic reaction where it's fight and flight, right, you're going to get bronchodilation, so we can maximize the amount of ventilation at the levels of the alveoli. So good job on that. All right. So looks like the majority of y'all got this correct. So the patient is overdosing on fentanyl. That's going to be one of the major things that happens in a drug overdose is going to be respiratory depression, at least with opioids. It's going to be respiratory depression, particularly when they combine opioids with alcohol or benzodiazepines. Those are going to be some very dangerous combinations of drugs. And what happens when you undergo respiratory depression? You're not able to breathe out as much carbon dioxide as you otherwise would. And so now you're going to become hypercapnic. That means you have too much carbon dioxide in your blood. Hypercapnia is going to result in respiratory acidosis. So you're going to become acidotic as a consequence. All right, looks like we got a mixed bag here. Okay, so what is the total lung capacity? What does that mean? Any volunteers? Yeah, including what? Yeah, exactly. So it's all the air in your lungs, all the air that your lungs can uh, accommodate, plus the residual volume. Okay, so that's going to be the total lung capacity. So effectively, you're just adding up all of the different values. You're adding up the inspiratory reserve volume. You're adding up tidal volume. So that's going to give you your total lung capacity. So make sure you know how to calculate that. So let's do another one of those. All right, so most of you guys got that correct. So vital capacity, that's all the air that your lungs can accommodate, but minus the residual volume. Okay, so it's going to be the expiratory reserve volume plus tidal volume plus the inspiratory reserve volume. Okay. It's it's everything except for the residual volume. Yep. Yep. All right. It's like half and half. So interalveolar pressure versus interpleural pressure. What's the interpleural pressure? Where do you find that? Huh? In the pleural space, right? Is that going to be kind of like a vacuum in there? It's kind of supposed to be like a theoretical space. You're not really supposed to have anything in there. There's going to be some like fluid to be able to reduce friction as you're breathing, right? So the pleural space, you're not supposed to really have anything in there. And as a matter of fact, it's supposed to be in kind of like a vacuum, right? So it's going to be about 4 millimeters of mercury less than the interalveolar space. So generally speaking, the interalveolar space is going to have a higher pressure than the interpleural space. So interalveolar pressure greater than the interpleural pressure. All right? Make sure you guys know that. It's definitely going to be on your test. Good, good. Most of you guys got that correct. So if you want to calculate the pulmonary minute volume, that's just going to be your tidal volume multiplied by your respiratory rate. So for this person over here, their tidal volume was 500. You're literally just doing 500 times 20. And so that's going to give you a value of 10,000. Okay? So nothing really too crazy there. Pretty straightforward calculations. I'm not gonna make you do the alveolar volume. That would have to include the amount of dead space. I'm not going to give you any questions about that, but just kind of have an understanding of dead space and how that comes into play with these types of calculations. It looks to me like most of you guys got this one correct. So that's awesome. Awesome. Most of you guys got this right. So that's perfect. Barrel chest, cyanosis, purulent sputum, basically chronic bronchitis, and then 50-pack year history of smoking. When you guys do like physical exams on a patient and you do part of their like social history, you're also going to talk about alcohol consumption, drug use, and you're also going to talk about the consumption of like cigarettes. And generally, the way that we measure the amount of smoke that a person smokes, we do it in pack years. And so each pack of cigarettes has 20 cigarettes in it. If you smoked 1 pack of cigarettes per day for an entire year, that's 1 pack year. If you smoked an entire pack of cigarettes per day for 20 years, that's 20 pack years. If you only smoke 10 cigarettes for a period of 20 years, 10 cigarettes per day over 20 years, that would be considered 10 pack years. So if you look up online calculating pack years, that's how we do it. It's nothing really too crazy. I'm not going to test you guys on that, but that's something that you're going to hear in the future when you're working in your clinicals. What's up? With vaping? Vaping is mostly water vapors. So like the major components of vaping that might be concerning is I think it's propylene glycol. If I remember correctly, it's one of the solvents that they use. And then if it's nicotine products, nicotine can potentially give you like hypertension. That's usually kind of transient. The biggest concern is with products of combustion. With vaping, you're not combusting anything. You're basically just turning it into water vapor, and that's what you're inhaling. But with cigarettes, cigars, pipe tobacco, marijuana, things like that, anything that you smoke, those are products of combustion. And whenever you combust stuff, you're getting a lot of different chemicals and compounds that are going to be potentially damaging and potentially carcinogenic. There's honestly not that much information yet on vaping and some of like the potential long-term consequences of vaping, so I can't give you a really good definitive answer on that. All I know is that if I were to choose the lesser of two evils, vaping seems to be a little bit more safer, but I'm not condoning it, all right? That's not my medical advice. Don't tell on me. Good. Most of you guys got that right. What's Dalton's law? Yeah, the partial pressure is you add up the partial pressure of each component, and then it gives you the total pressure. What's Henry's law? Gas, right? So think about like soda water or something like that. Lope's law. We're not going to talk about that. It's a subject for another time. Last one. Just talked about that. All right, I hope this is 100% correct because we just talked about it. All right. All right, good job. Let's see who the winner is here. All right, congratulations, Humberto. Right on. Get a high five. All right, let's talk about red blood cells and hemoglobin. Okay, so this is where things get kind of, it's pretty straightforward stuff, honestly. So when when you breathe in, right, so that's going to be like external ventilation, right, and then external respiration taking place at the alveoli. All of the gas exchange that's taking place is just going to be simple diffusion. So you're going from high concentrations to lower concentrations. That's effectively what's going on. Carbon dioxide as well as oxygen are both going to be lipid soluble. So that means that they diffuse right across membranes. Okay, so the type 1 pneumocytes, those are going to be the thinnest of them all. They're just going to be very simple squamous type epithelium. And carbon dioxide and oxygen are both going to easily be able to travel right across those layers just via simple gas diffusion. In the pulmonary artery, remember arteries bring blood away from the heart. Pulmonary artery is going to be bringing blood from the right side of the heart to the lungs. Okay, right side deoxygenated. It's going to be deoxygenated blood. And so the partial pressure of oxygen is going to be pretty low. It's going to be about 40 millimeters of mercury. So that's going to be your from your venous system. So that's the point where the oxygen level is the lowest. It's going to be at the pulmonary artery. Once it gets to your lungs, then it's going to get oxygenated. And as it gets oxygenated, it's going to be at around 100% millimeters of mercury. Now, this figure is actually a little bit inaccurate. It's never going to be completely 100% saturated. Okay, so we're going to talk about that in a second. But it's going to be pretty close. It's going to be around like 97 point something percent saturation, assuming nothing wrong is going on with the patient, assuming that you don't have pneumonia or COPD or asthma or something like that. This is just like a healthy individual. So when the blood is entering into the pulmonary system, the pulmonary circuit, it's going to be very low in oxygen, and it's going to be relatively high in carbon dioxide. Okay, so those are going to be the partial pressures of each of those gases. So it's going to be low oxygen, high carbon dioxide. As you start getting into the arterial system, well, as you start getting into the oxygenated side of the vessels, then you're going to start getting a higher partial pressure of oxygen and a lower partial pressure of carbon dioxide. Okay, so it's pretty straightforward stuff. Oh yeah, and by the way, external respiration. So you remember that external, think about the alveoli as being exposed to the outside world. So it's going to be considered external respiration. Internal respiration, that's going to be at the levels of your cells, right? That's going to be peripheral vascular system. So these are the things that play into or have effects on the way in which oxygen and carbon dioxide are diffused. So differences in partial pressure, right? So if you go from high partial pressure to low partial pressure, now that difference, that pressure gradient, you're going to go from high to low. So that's just simple diffusion. The distance, that's going to be really important, right? So you have a very narrow distance from the alveoli to the endothelial layer of the capillary bed. So it's a very small distance, so the gas doesn't have to travel very far. Oxygen and carbon dioxide are both lipid soluble, so they travel right across the epithelial layer with no problem whatsoever. Another thing that's important with the alveoli, you have a really large surface area. The surface area, depending on what textbooks you look at, some textbooks say that it's about the size of a tennis court, so that's a pretty decent estimate to kind of gauge the amount of surface area of alveoli that you have in your lungs. There's other texts that say different values, but you know, it's kind of a good ballpark estimate. And then also other things that come into play is going to be airflow. We're going to talk about ventilation and perfusion and the airflow and the things that control respiratory rates. Okay, so we're going to talk about that when we get into the neurological centers of the brain that control respiration. When you get into your peripheral tissues, you're going to be dumping oxygen into those cells, right? And it's going to be especially determined by the amount of demand in those cells. So for instance, if you're out exercising and you're using your skeletal muscles, you're using your legs to be able to run and jog, you're going to have a higher demand in those cells within your legs for oxygen. And so you're going to get more oxygen consumed, and then you're going to have more oxygen being brought to those regions, and you're going to have more oxygen unloading in those areas. So in other words, where you have higher demand, you're going to have a greater difference in the pressure gradient. Okay, so in other words, the pressure gradient is going to go from your blood has a lot of oxygen, the hemoglobin is going to get dumped off onto the tissues that have a higher demand, aka they have less oxygen because they're using up a lot of oxygen for the sake of metabolic activity. So pretty straightforward stuff. That's going to be at the level of the capillary beds. Generally speaking, when oxygen is leaving your lungs, it's going to be around anywhere between like 95 to like 97 partial pressure of oxygen. And then once it leaves the capillary beds and it unloads all the oxygen, it's going to drop down to about 40 in terms of its partial pressure. And that's going to be internal respiration at the cellular level. So let's talk about hemoglobin a little bit. So your red blood cells are going to be jam-packed with hemoglobin. You have lots of hemoglobin in every single one of your erythrocytes. So each erythrocyte is going to have around 280 million hemoglobin molecules. Each of those hemoglobin molecules can carry 4 oxygens, right? So they're going to be binding to the iron sites on each of the different hemoglobin chains. So you have 2 alpha and you have 2 beta chains on your hemoglobin. So those are going to be each binding to an oxygen. Carbon dioxide can also bind to hemoglobin. We're going to talk about that in a second. Carbon dioxide doesn't bind to the iron on the hemoglobin. It's going to be binding to the free nitrogen groups on the hemoglobin. It's just so that you don't get competition for oxygen binding. So it's going to be binding to a different site on the hemoglobin, but we'll talk about that in a second. So this is what your oxygenated hemoglobin looks like. We refer to it as oxyhemoglobin, where you have every single one of these chains are going to be bound to an oxygen. Okay, so that's going to be fully saturated hemoglobin. As oxygen gets released from the hemoglobin, then you are getting into deoxyhemoglobin, right? So deoxy is deoxygenated, doesn't have as much oxygen. There's also going to be a compound that's going to be referred to as either 2,3-DPG or 2,3-BPG, like B as in boy. It's 2,3-disphosphoglyceric acid, or some other texts refer to as bis-phosphoglyceric acid. Or it's diphosphoglyceric acid or bis-phosphoglyceric acid. Either one are going to be referring to the same thing. So 2,3-DPG or 2,3-BPG. And when you have binding like that with the 2,3-DPG, that's going to stabilize the deoxyhemoglobin. So it's going to stabilize it, so it allows the oxygen to get released in tissues that require oxygen. Okay, so 2,3-DPG is going to play a very important role in stabilizing deoxyhemoglobin. And then these little values over here are going to be, we're going to talk about in more detail, but as you increase your hydrogen ions, aka you are becoming more hypercapnic, you're becoming more acidotic, that's going to result in more deoxyhemoglobin, right? That's going to be something that kind of like pushes towards that direction, deoxyhemoglobin. If you have increased levels of 2,3-DPG, that's also going to increase the amount of deoxyhemoglobin. And then if you have less oxygen, obviously that's going to result in deoxyhemoglobin. And then the opposite is true. If you increase the partial pressure of oxygen, now you're going to get more oxyhemoglobin as a consequence. So this is going to be kind of it's a little kind of daunting at first, but once you get the concept, it's pretty straightforward. But this saturation curve, this is the oxyhemoglobin saturation curve, which is going to be determined by a couple of different variables. It's going to be determined by the partial pressure of oxygen. It's also going to be determined by temperature, and it's also going to be determined by pH levels. And so we're going to talk about how this curve is going to either go to the left or go to the right, depending on what kind of variables are coming into play, temperature as well as pH. Now, here's the question that here's the thing I was mentioning earlier. You're not fully going to get 100% saturation of your hemoglobin. It's always going to be hovering around 97.5-ish, depending on what text you're looking at, but it's not going to be fully 100%. Now, the reason for that is because as you're breathing in, right, as your circulatory system is pumping blood through your pulmonary circuit, and as you're breathing oxygen in, right, so you have deoxygenated blood coming into your lungs, then all of a sudden they're going to get oxygenated at the level of the alveoli. Some of the blood that's pumping through the pulmonary circuit is not going to go straight to the alveoli. Some of that blood is going to actually have to oxygenate the pulmonary tissue itself, right? Because the lungs need oxygen as well for them to be able to function properly. And so that's why you're never going to get a full 100% oxygenation. Now, there's a fun little video. I'm going to play a very brief period of it because the guy has like the thickest accent on earth and it's kind of hard to understand. But
Hello students, welcome to our channel नीलांबर। बच्चों आज की कॉमन डाउट को स्टूडेंट इसमें मैं डिस्कस करने वाला हूँ why hemoglobin saturation with oxygen is never 100%। बेटा आप लोगों ने ऑक्सीजन हीमोग्लोबिन डिसोसिएशन का जरूर पढ़ा होगा ऑक्सीजन ट्रांसपोर्ट के अंदर। तो ग्राफ में आप लोगों ने देखा होगा कि हीमोग्लोबिन का जो सैचुरेशन होता है ऑक्सीजन वो कभी भी 100% पर नहीं जाता, उससे हमेशा कम ही रहता है, यानी 97% तक ही रहता है। तो सैचुरेशन 100% क्यों नहीं हो सकती है? तो देखो बेटा इसको
this chart is the best chart that helps to summarize this.
लंग्स का पहले 65 स्ट्रक्चर ड्रॉ कर दिया है। लंग्स के अंदर दो पार्ट हमारे पास प्रेजेंट है, कंडक्टिंग पार्ट और दूसरा रेस्पिरेटरी पार्ट। कंडक्टिंग पार्ट वो होता है जिसका काम सिर्फ एयर को कहां तक लेकर आना होता है, एल्वेओलाई तक या फिर रेस्पिरेटरी पार्ट पर, जहां पर कोई भी गैसेस एक्सचेंज
I felt like I'm back in med school again. I swear, like half of my teachers had that same exact accent. So what he was showing over there with the conducting part is going to be the rest of the lung that also requires oxygenation, right? So blood is going to be going to the conducting part as well, a small percentage of it. But the vast majority of the blood that's going to the lungs is going to be going to the levels of the alveoli. And so you're going to get majority of your blood is going to be oxygenated, but it's never going to be quite 100%, as the gentleman in the video explained. Cool. So it's another thing to keep in mind about the the saturation curve is that it doesn't go in a straight line. It doesn't go in a straight line because of a number of different variables. But one thing that's kind of interesting about hemoglobin is that as you get more oxygen binding to those different binding sites on the hemoglobin, you get an increased binding affinity for hemoglobin. Remember, because there's like 4 different binding sites. As you get one oxygen binding to that hemoglobin, it's going to have a greater affinity as you get more and more oxygen binding to those other binding sites as well. So that's why you're going to see this kind of a curve type formation. So take a look over here. This is the partial pressure of oxygen. This would be if you're like in a hyperbaric chamber where you have 100% oxygenation taking place, and then you would get really close to 100% saturation of your hemoglobin. Not quite in reality, but you'd be getting very close to that. Now look, as you dip down to about 30 or so percent partial pressure of oxygen, that 30%, you're still going to get 50% saturation of your hemoglobin. So in other words, half of your hemoglobin is still going to be saturated, even though you don't have 50% oxygen. You have only about 25, 30% oxygen at that point. But despite that, you're still going to get a lot of oxygen remaining bound to hemoglobin. That's just because hemoglobin has a very high affinity for binding to oxygen. The term that we use for that is positive cooperativity. So that's all going to be due to those different conformational changes. The shape of the hemoglobin actually changes and adjusts as you increase the number of oxygen molecules binding to those different sites. So that's kind of a fun, interesting thing to take into consideration. These are other things that are going to affect that curve. Okay, so obviously partial pressure of oxygen that you're breathing in, how much oxygen you're actually able to get down into your alveoli, that's going to have a huge effect. The blood pH is also going to have a very significant effect on the way the hemoglobin oxygenation curve looks like. Temperature is also going to have a huge effect. And metabolic activity within the red blood cells is also going to have a very huge effect. The way that you can conceptualize this is, say that you're running, right? You're jogging or you're exercising. What happens when you use your muscles when you're exercising? What starts building up? Why do you get the burn? Lactic acid, right? So lactic acid, it's acidic, right? So it's going to be low pH. As you lower the pH, you're going to dump more oxygen off at those tissues because those tissues obviously need more oxygen. So whenever you have low pH, you're going to have a shift to the right in terms of that oxyhemoglobin saturation curve. So in other words, percent saturation is actually going to dip because the hemoglobin wants to dump off that oxygen in those tissues so that they can meet the demand for metabolism. Same thing with temperature. As temperature increases, think about your exercising, right? All of a sudden your basic metabolic rate goes up. Now you're exercising, you're getting warm. So when you start getting warmer, you're also going to be dumping off more oxygen in those tissues so that you can try to meet that demand. And then the opposite is true. The more alkalotic you become, you are going to be increasing the percent saturation of oxygen on hemoglobin. As you decrease temperature, you're going to be subsequently increasing the oxygen saturation on the hemoglobin. So we're going to go through a couple problems on that if you find those concepts a little confusing, so don't worry. We'll talk about that in a little bit. Now, we already talked about simple diffusion, right? So oxygen is going to be diffusing from high partial pressure to areas of low partial pressure to especially meet demands. And then interstitial partial pressure of oxygen, that's going to be at the level of the tissues. That's going to help determine the way in which oxygen is able to be directed. Is it going towards a low concentration gradient? That's going to be determined by the amount of oxygen levels within the interstitial space. And then here's the key. To me, this is the key thing, is inactive tissues. Okay, so if you have inactive tissue, you have low oxygen demand. You do not need as much oxygen in those tissues. So they're going to actually have a higher partial pressure of oxygen, right? They're not undergoing active metabolic, they're not going to be undergoing high metabolic activities. So you're going to have higher partial pressure of oxygen in those tissues. So here's a really good summary of what you're going to see with the the hemoglobin percent saturation curve. So low pH, right? So you think about being lactic acidosis if you're working out. So low pH, also high temperatures. Now, those areas require more oxygen, increased oxygen demand. You're going to be dumping oxygen off into those tissues. And so you're going to get a shift of this curve to the right. Okay, so here's your oxyhemoglobin or percent saturation. Your hemoglobin saturation is going to drop, right? Because you're going to be releasing oxygen. And so that's why you see a shift to the right when you have decreased pH, increased temperature. And then the opposite is true. If you have increased pH, decreased temperature, you're going to see this curve shifting to the left. Okay, so in other words, the percent saturation of hemoglobin is going to start increasing because you don't have as much demand for oxygen. So the hemoglobin is not going to be dumping off oxygen into those peripheral tissues. So this is what that looks like if you were to put this chart together in terms of pH as well as in terms of temperature. Okay, so it's pretty straightforward stuff. As you become more acidotic, then you're going to start dumping oxygen. So you're going to reduce the overall saturation of hemoglobin. As you become warmer, same thing. You're going to reduce the percentage the percent saturation of hemoglobin. So pretty straightforward stuff if you understand the concept. Just think about exercise and demand. That's going to be able to help you conceptualize how that curve works. Cool. So let's talk about carbon dioxide, because carbon dioxide is pretty interesting. Oxygen is pretty straightforward. It just binds to the iron binding sites on hemoglobin. Nothing really too crazy. Carbon dioxide, however, is a little bit more interesting because there's going to be a couple different ways that carbon dioxide gets transported throughout the body. When carbon dioxide is in solution in your body, there's going to be an enzyme. This enzyme is carbonic anhydrase. Carbonic anhydrase is able to convert carbon dioxide gas into carbonic acid. Carbonic acid is also going to be able to turn into hydrogen ions and bicarbonate ions. Now, this is the reason why carbon dioxide is associated with becoming acidotic, right? So once it becomes carbonic acid, then you have this whole thing going on, the Bohr's effect, where you're having, it's going back and forth into different states of free hydrogen ion plus bicarbonate. So that's going to be an acidic type solution. That's why when you're hypercapnic, you're going to be having respiratory acidosis. So you're going to be becoming acidotic as a consequence. Now, carbonic acid is pretty interesting because it's going to be the most, that's going to be how do I say this? 70% of all your carbon dioxide is going to be in the form of carbonic acid, basically. So as carbon dioxide gets diffused into your blood, some of it is going to be diffused and dissolved into plasma, a very small percentage, about 7%. Some of it is going to actually bind to hemoglobin, so not really a lot, but 23%. And it's going to be binding to those free nitrogen regions on the hemoglobin. It's not going to be binding to the iron sites. But the majority, 70%, is going to be in the form of carbonic acid. Okay, so that's going to be the most amount of carbon dioxide. Most of the carbon dioxide you see in your body is going to be in the form of carbonic acid. Now, the thing that's interesting about carbonic acid is that you're going to see chloride ions diffusing across in exchange for bicarbonate. And so that's going to be kind of part of the whole entire way that blood kind of acts as a buffer, right? So it's going to be controlling pH levels. This is going to be one of the mechanisms where you have the controlling of pH levels at the level of blood. So, to reiterate all the things that we just talked about, we discussed briefly 2,3-BPG and the role that 2,3-BPG plays. So it's either BPG or DPG, depending on what you prefer. That's going to help stabilize the deoxyhemoglobin conformation. When you do get that BPG increase, allowing for stable deoxyhemoglobin, then you're going to get a shift to the right, right? So that means you're going to reduce the amount of oxygenated hemoglobin or oxyhemoglobin. So you'll get a shift to the right. In other words, this curve right here, it's going to dip down because your oxyhemoglobin levels are going to drop. This can actually be affected by whether or not you're traveling to like higher elevations, higher altitudes. For instance, if you're taking a trip to the Andes or something like that, maybe you're visiting Machu Picchu. Some people actually get mountain sickness when they go to higher elevations if they do it too rapidly. Some of the reasons that they get that is just they have issues with the levels of carbon dioxide in their blood and whatnot. But over a period of time, your body is able to acclimate to higher elevations by increasing the levels of BPG. So as you go to areas where the oxygen is a little bit thinner, you're not getting as much partial pressure of oxygen. Your body is going to have a higher demand for oxygen, right? So in order to meet that demand, BPG can actually be increased in your body to help meet those oxygen demands. And this is just a side note about the T state versus the R state. The T state, that's going to be with deoxyhemoglobin. And when you have BPG or DPG, that's going to allow for stabilization of that T state. So don't worry about that too much. That was just a side note, just in case that terminology was a little confusing. So let's talk a little bit about the Bohr effect before we finish up here. So this is kind of a good summary of what we were just talking about in terms of the shifting of the curve from the right or to the left. So if you're exercising in order to meet the demand of those tissues, you're going to see changes in pH, you're going to see changes in temperature, and all those changes are going to help unload oxygen into those tissues. Okay? So that's going to allow for a shifting of the curve to the right. Pretty straightforward stuff. Now, let's talk about the effects of hyperventilation. We discussed that a little bit earlier, but when you're hyperventilating, what's going on? You're breathing off more carbon dioxide. Okay, so you're breathing off a lot of carbon dioxide. As you do breathe off the carbon dioxide, now you're going to start becoming alkalotic. So you're going to undergo respiratory alkalosis, and then you're going to get a shift to the left. Okay, a shift to the left of the oxyhemoglobin curve. If you had an asthma attack, that means you're not able to get air in and out of your lungs adequately. This is going to result in respiratory acidosis. If you get respiratory acidosis, then oxygen is going to start dumping off of your hemoglobin. So in other words, your oxygen saturation curve is going to shift to the left. So if you did a pulse oximeter on a patient that was undergoing an active asthma attack, you would see that their oxygen saturation levels would actually be low because of this. Okay? All right. So let's briefly discuss fetal hemoglobin. So as a child is developing in the womb, the child is going to require a lot of oxygen to be able to meet, their demand for growth and to be able to meet their metabolic needs. And so fetal hemoglobin is going to be a little bit different than adult hemoglobin. Adult hemoglobin, you have 4 different chains, right? But two of which are going to be alpha chains, 2 of which are going to be beta chains. With fetal hemoglobin, you have 2 alpha chains, but you're going to have 2 gamma chains. The thing that's interesting about fetal hemoglobin is that it's not going to bind to BPG. Now remember what BPG does. BPG is going to stabilize the deoxyhemoglobin state, right? So it's going to allow for stabilization of hemoglobin without oxygen on it. But because as the fetus develops, it's going to need a lot of oxygen. It's not going to want to bind to BPG. So in other words, you're going to have a higher binding affinity with fetal hemoglobin. So fetal hemoglobin is able to bind more readily to oxygen than adult hemoglobin. So in other words, you get a shift to the left, right? So your oxygen saturation is going to be a little bit higher with fetal hemoglobin. So let's finish up with, we just kind of covered a lot of these topics. We're going to go into more detail about this. We're going to have to continue on with the rest of this on Thursday. Do you guys have any questions before we wrap up? You have a question. What's up? The what? Boils? Oh, Bohr's effect. Bohr's, where you go from with carbonic anhydrase and it turns into carbonic acid. What about it? With an asthma attack, if you're not able to get enough oxygenation, or actually if you're trapping oxygen in your lungs and you're not breathing off enough carbon dioxide, then carbon dioxide is going to start accumulating within your body. Right? So as carbon dioxide accumulates, then you're going to get an increase of carbonic acid. You're going to become more acidotic. As you become more acidotic, then you're going to get a shift to the right. And so in other words, oxygen is going to start getting dumped off into areas where it shouldn't be getting dumped off into. I can cover that again on Thursday, just in a little bit more detail. Yeah, no, you're fine. Awesome, guys. Well, it's good to see you all again. I'll see you guys on Thursday. Have a great day.